Hello, everyone. My name is Dr. Shondra Loggins Clay, and today I will be presenting on factors contributing to adverse pregnancy outcomes for Black women, pre-pandemic and now. First and foremost, I want to give a warm thank you to the Aurora African American Health Coalition. I really appreciate you all having me. I am excited to talk about Black women and health outcomes for Black women, whether it's maternal health outcomes or maternal and child health outcomes. So again, thank you. And I look forward to hearing your feedback at the end of this presentation. So just as an overview of the presentation, first I will start with some background information, also some significance about the topic. This will include a historical overview of the topic as well as some current trends. I'll also talk about the impact of COVID-19 as it relates to Black maternal outcomes. And then I'll report a little bit about research findings from my own research, give you an overview, report some important findings. And then I'll discuss some selected publications and also go into some future research plans. And hopefully this will lead to a future discussion about recommendations, what can be done to improve the outcomes for Black African Americans as it relates to maternal and child health. And so just to set the stage for this presentation, I think it is very important to give a little bit of context, background regarding the significance of this health issue. And so first I want to start out by just discussing maternal health. And this is a significant problem within the US. And so this chart shows the maternal mortality ratios in selected countries from 2018 or the latest year. And so just to preface, looking at some of the data, the maternal mortality ratio is defined by the World Health Organization as the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of the pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. And so I do want to give credit to the source of this information. This was taken from the Commonwealth Fund, Maternal Mortality and Maternity Care in the United States. And one thing that I want to point out here is that the US at the very end, color coded in orange, had the highest maternal mortality ratios in 2018. And this is compared to other countries. So we see France, Canada, Sweden, Australia, Germany, just all the different countries. The maternal mortality ratio for the US was 17.4, which is higher than any other country from this visual display. And if you look at the comparable countries, you'll see that it is almost twice the ratio of other comparable countries. And this is a problem. And so if we look at this data by race and Hispanic origin, you'll see that the issue arises with non-Hispanic Blacks. And so if you take a look at the data by race, you'll see that non-Hispanic whites have, in 2018, have a maternal mortality rate of 14.9. Whites have a maternal mortality rate of 17.9 in 2019. But if we look at Blacks in 2018 and 2019, the maternal mortality rate is again almost double. So non-Hispanic Blacks in 2018 had a maternal mortality rate of 37.3. In 2019 had a maternal mortality rate of 44. And even if we take into consideration Hispanic persons, we see that that number is almost triple. And so Hispanic persons in 2018 had a maternal mortality rate of 11.8, and in 2019, 12.6. And so in 2018, it was 11.8, 2019, 12.6. And so the purpose of showing this is that, yes, the US maternal mortality rates are high, but this is really attributed to the non-Hispanic Black population. As you can see here, the rates are significantly higher than other racial and ethnic groups. Since we are in Illinois, I want to look at the Illinois data as well. And the Illinois data really reflects what we see on a national scale. And so if we look at the pregnancy-related mortality ratio by demographics, and so this is from the Illinois Maternal Morbidity and Mortality Report. Again, if we look at the race and ethnicity, the rates for non-Hispanic Blacks, it double and triple those of non-Hispanic whites and also Hispanic persons. And so the data from our maternal health perspective is very similar to what we see in child health and our infant mortality rates. And so if we look at infant mortality rates by race and ethnicity, this was taken from the CDC Wonder, which presented data on infant mortality in the United States from the period linked birth infant death file. If we look at this data, again, we start to see the trends that emerge from the data. If we compare the infant mortality rates of non-Hispanic Blacks to other group dynamics, such as Hispanic persons or non-Hispanic whites or Asians, we see that that number, again, it double the rate of certain group dynamics. And again, I want to bring this back to looking at Illinois data. If we look at the infant deaths or infant mortality rates in Illinois, the data is very similar to what we see nationally. Again, Blacks, the infant mortality rates are higher, much higher than those who are white or other racial and ethnic groups. So after looking at this data, the question that remains is, what are we attributing these high or escalating maternal mortality rates and infant mortality rates to? And so if we look at the literature, what is the research saying? And so the research says that we really must start looking at social determinants of health. Social determinants of health, they're a major contributor to many of the racial health disparities that exist. And so some of those social determinants of health that have been identified from the literature include education attainment levels, income, racism, mistrust, discrimination, healthcare accessibility and affordability, and also the environment. So those are just some of the social determinants of health that we see are driving some of the racial and ethnic health disparities that we see in maternal and child health outcomes. Also, some of the literature really alludes to structural racism and institutional policies. And so this can include things such as redlining, which is related to income, refusing a loan or insurance to someone because they live in a certain geographic area that's deemed to be a poor financial risk, or things that are in place structurally like Jim Crow laws, which enforced racial segregation. And then literature also points to this idea of stress. You may have heard of, for example, the weathering hypothesis. And this is saying that basically because of the stress that certain racial groups endure, it biologically, and physiologically, it age the woman. And this stress has an impact on the health outcomes of women, particularly Black women, who experience a different type of stress. And so I wanted to kind of recap some of the literature, but I also wanted to share just some theoretical frameworks that also talk about disparities. And so this is the Kaiser Foundation theoretical framework about social and economic factors that drive health outcomes. And this is directly related to maternal and child health, as we're starting to see some commonality between some of the factors that are really driving these health disparities, these differences when it comes to health outcomes. And so according to this framework, it can be categorized as economic stability. Again, this is referring to the income that we just discussed from the social determinants of health, employment, expenses, debt, medical bills, support. The second tenet is the neighborhood and physical environment. This can refer to housing, transportation, safety, parks, playgrounds, walkability, zip code, geography. Education is the third area. Literacy, language, early childhood education, vocational training, higher education. Food, this relates to food insecurity or security, access to healthy options. And then we have two more kind of areas that really drive health outcomes: the community and social context, as well as the healthcare system. The community and social context relates to social integration, support systems, community engagement, stress, exposure to violence, trauma. And then the healthcare system relates to health coverage, provider availability, provider linguistic and cultural competency, the quality of care. And all of this is also related to racism and discrimination, which is kind of the hovering the umbrella term that is embedded in each one of these factors that drive health outcomes. And so the health outcomes that this theoretical framework refer to include mortality, morbidity, life expectancy, healthcare expenditures, health status, functional limitations. And so all of these social and economic factors really drive health outcomes in these areas. And these are some of the major factors that drive health outcomes, specifically in maternal mortality, as well as infant and child mortality as well. Another theoretical framework that I like to use to kind of conceptualize this idea of health disparities in Black maternal and child health is the ALIO framework. And this is an ecological approach to understanding Black-white disparities in perinatal mortality, which was in the Maternal and Child Health Journal. And so if you look at this theoretical framework, it really relates to the Kaiser family framework. In the larger context, we have racism that is embedded in each one of the tenets influencing health outcomes. And so the health outcomes are paternal birth, low birth weight, infant, and then several other ones. But really, the things that are influencing those outcomes really include the parent and family. So this is kind of the individual level, things that individually impact those health outcomes, and then the community and societal context, which broaden those characteristics of things that have an influence on health outcomes. And so as it relates to some of the individual level, parent and family, we have things like single parenthood, maternal age, and internalized racism. These are, again, some of the examples of the individualized level things that, or the household level things that may influence health outcomes. And then we have the societal, the community and society context that drives some of those health disparities. And this can include neighborhood characteristics, personally mediated racism, socioeconomic status, poverty, cultural competency, access to quality care, and institutionalized racism. And so when we think about those drivers of health outcomes, and we think about the health disparities that exist, the racial and health disparities exist, we'd be remiss not to discuss the impact of COVID-19 and how it has really exacerbated those issues to influence negative health outcomes. And so some of the impact of COVID-19 as it relates to Black maternal health, one, telehealth. And so as it relates to telehealth, it has many advantages. I do want to preface this conversation with that. But when we're talking about Black maternal health and just race in general, telehealth can have some disadvantages as well. And some of the disadvantages include, for example, hindering early detection or lack of focus. We all know that, when we have been virtual, that sometimes there are things that can really just impact us and take away our focus and our attention on what we're looking at. And this can also be related to telehealth appointments, and it can have an influence on those health outcomes. Accessibility of healthcare. And so because of COVID-19, it's made it very difficult to attend appointments with others. And so you have that lack of support that, I really think that all women, particularly Black women, really need. You have a lot of social isolation because of COVID-19, and also the hospitals are overwhelmed. And so because of this, the accessibility of healthcare during COVID-19 has really been an issue. And I'm pretty sure that future research will definitely support that not having accessible healthcare during COVID-19 has really also negatively influenced health outcomes for Black women. Stress. So I talked about the weathering hypothesis, and we can only imagine we actually lived through some experiences of stress during COVID-19. And so relating this back to the weathering hypothesis, we can probably definitely draw a correlation or some connection to stress, the impact that stress has had on the body, particularly of Black women, and how stress may look different for Black women during the pandemic. Again, negatively influencing those health outcomes and those pregnancy outcomes. Financial anxiety, unemployment, that is another level of stress. And also we talked about the social determinants of health. And so looking at those education attainment levels, the impact of COVID-19 is that those social determinants of health that have already been linked to racial health disparities, they have been exacerbated. And so education, neighborhood, racial segregation, maternity care deserts, food deserts, all of those things that we saw in the theoretical framework, they're magnified because of COVID-19. And so I want to bring this all together. We have discussed the significance, what's going on, a historical overview of Black maternal health, what's going on, what is the impact of COVID-19. We've discussed that. And so now I want to bring in a little bit of research, my own research, to just kind of further elaborate on what have we found about Black maternal and infant health that speak to kind of those health disparities. And then I will conclude the talk by discussing some recommendations going forward. And so I wanted to discuss a few recent publications that I published, as well as with some of my colleagues. And so I will be discussing 4 articles, publications specifically. One, to kind of again set the or kind of preface this talk about or with the trends in infant mortality rates. And then I will discuss some findings about looking at some of those outcomes and some of those factors according to some of those theoretical frameworks that we discussed before. And then again, I will offer those recommendations. And so in a recent publication, this study was titled U.S. Infant Mortality Rates and Exploration of Black-White Disparities, Current Trends, and Social Inequalities. This publication was published in Race and Social Problems, this journal. It is available if you want to review the article. But essentially, the purpose of this paper was to explore 10-year trends in infant mortality rates between 2007 and 2016 for non-Hispanic Blacks, non-Hispanic whites by level of social demographic characteristics such as maternal age, marital status, education, and access to prenatal care. And so I want to present the purpose, and then I'll highlight some of the key findings from the study to kind of bring this all together. And so the key findings from the study, in this study, a measure of disparity was created. So we're always talking about disparity, but how much of a disparity do we see, a racial disparity do we see in these health outcomes? And so a couple of key findings from the study was, one, some good news. The infant mortality rates for non-Hispanic Blacks, it's declining at a faster rate compared to non-Hispanic whites. However, that disparity still exists. So Blacks have such a high, and this is going back to the charts that I presented in the beginning of this presentation. Blacks have such a higher infant mortality rate than other racial and ethnic groups that even though we see this decline, and it's declining at a faster rate, we still have this disparity. And so again, this is good news that the rates are declining at a faster rate, but we needed to decline even faster so we can get the numbers down to be comparable to other group dynamics. As for the selected socio-demographic indicators, we noticed reductions for both racial groups for most age categories assessed, married and unmarried women, and for women with early or no access to prenatal care. And so again, this is good news. We're seeing declines across both racial groups. And this is what we want to continue to see. For educational attainment levels, declines were observed for both racial groups for all levels except for high school graduate or GED and some college, in which increases were observed for non-Hispanic white women. And so eventually we need to see what's going on there, what's causing the increases for non-Hispanic white women. But the good news is that declines were observed for both racial groups for all levels of educational attainment. Again, the measure of disparity, it illustrates that a large racial gap in infant mortality rates, the outcomes, the pregnancy outcomes, persist between non-Hispanic Blacks and non-Hispanic whites. And so again, even though we're seeing this fast decline, we still have this disparity gap between non-Hispanic Blacks and non-Hispanic whites. And I'll talk a little bit more about the recommendations, but more structural and systemic mechanisms, including research and policies, they're needed to address the disparities in infant mortality rates. And so this was another publication looking at low birth weight pregnancy outcomes, looking at the differences between some healthcare factors and health system factors, and just seeing what's really causing the Black-white disparities that we see exist. And so the purpose was to determine if there are racial differences between non-Hispanic Blacks and non-Hispanic white women in healthcare factors associated with low birth weight, to determine if there are differences across health system factors, and to explore if the factors account for the racial differences. And so in this study, some of the care factors that we explored were checking on pregnancy during the time that the mother was pregnant, having or seeing an actual doctor for prenatal care, breastfeeding intention, and a number of prenatal visits. And so these were more of the care factors. The system factors were a little bit more on a broader scale, or looking at it from a broader or a wider perspective. And so going back again to those theoretical frameworks that I presented in the beginning of this presentation, the system factors were more of like those contextual factors. So we looked at hospital stay, C-section delivery, the doctor for delivery, nursery, and the days in the hospital. And so some of the key findings of the study were that we still see this gap. The low birth weight percentage for non-Hispanic white women was 8.1%, whereas for non-Hispanic Black women, the low birth weight percentage was 13.6%. And so there's still that gap that exists. Non-Hispanic Black women who had a low birth weight baby, they were significantly more likely to be unmarried and earn less income. And I really want you to focus on that income part, because this is a theme that has been emerging in my research specifically. For level of care, non-Hispanic Black women were more likely to have low birth weight babies in neonatal care, whereas non-Hispanic white women, they were more likely to have low birth weight baby in well baby nurseries. Again, Black women were 1.7 times more likely to have a low birth weight baby compared to non-Hispanic white women. And even when we consider some of those health care factors, the disparity still existed. And it was even more prevalent when we accounted for or looked at, for example, health care factors. And so those care factors, again, were checking on the pregnancy, doctor for prenatal care, breastfeeding intention, number of prenatal visits. The likelihood of having a low birth weight baby, it increased to an odds ratio of 2.26. That means that non-Hispanic Black women, when we considered those things, those healthcare factors, the odds of having a low birth weight baby, it increased to 2.26. And this just shows us that we really have to look on what's going on in the doctor's office. So checking on the baby during pregnancy, that's related to the doctor's visit. Having a doctor for prenatal care, the number of prenatal care visits, because this increased the likelihood of having a low birth weight baby. Between the disparity between non-Hispanic Blacks and non-Hispanic whites, more research is definitely warranted in this area. And so I also did a research manuscript with some of my colleagues, Dr. Woodson and Dr. Kirsch, and we looked at some of the socio-demographic, economic, and environmental factors in Black-white disparities in low birth weight outcomes. And so, again, we talked about those specific economic and environmental factors from that Kaiser's Foundation theoretical framework. And so we looked at some of those factors and the impact that it had or have on low birth weight outcomes. And so the purpose of this article was to really explore the racial differences in influential socio-demographic, economic, and environmental factors in women who have had a low birth weight infant baby. And so some of the key findings were that there were statistical racial differences between non-Hispanic Black and non-Hispanic white women in the social demographic variable of marital status. And so along the lines of the income, we are also starting to see that marital status is different across the racial groups, and it's something that we need to explore further. Regarding the assessed economic stability variables, employment status, poverty level, earnings, and federal government assistance paying for rent, they were statistically significant across the two racial groups. So non-Hispanic Blacks and non-Hispanic whites. Some of those environmental factors that we saw that were different in women that had low birth weight baby were living in public housing projects, car ownership, neighborhood safety. And so really what the results of the study they're showing that there are differences between non-Hispanic Blacks and non-Hispanic white women who have low birth weight baby as it relates to some of these economic and environmental factors. And so it's really important to look at how economic and environmental factors are influencing some of the adverse outcomes that happen for Black mothers. And the last study that I really wanted to bring in was another one with some colleagues, Ms. Griffin and also Dr. Averhart. We did a study about Black-white disparities in pregnant women in the United States, really looking at the Black-white racial identity. So we wanted to explore racial disparities and risk factors of adverse pregnancy outcomes in Black and white pregnant women in the US. And as you'll see in this study, some of those same things were emerging. So Black women who were pregnant, they had a lower socioeconomic status. They experienced more measures of institutionalized racism compared to white women. More white women who were pregnant, they were married, had higher level of educational attainment, higher levels of income, greater employment opportunities. They had higher levels of private health insurance and less dependency on government programs for access to health care. The other findings indicated that Black pregnant women, they were less likely to be married, less likely to have higher income levels. So again, this is really pointing to income being a major driving force for adverse pregnancy outcomes, or a major driving force for differences, those health disparities. They were less likely to be employed. Black women, however, were more likely to be younger. In a study, we looked at some health eroding behaviors and also some of those contextualized factors. So for the health eroding behaviors, Black women were less likely to smoke and use alcohol, but we still see those disparities that exist. When we look at some contextualized stressors, such as access to healthcare, Black women were more likely to have Medicaid or CHIP and health coverage through government assistance program. However, they were less likely to have private health insurance. And so the conclusion was that we see it. There are differences in risk factors of adverse pregnancy outcomes for white and Black pregnant women based on the measures of individual social stressors, institutionalized racism, health behaviors, and access to care. And so I want to bring this all together as it relates to current research, future plans, and then tie in some recommendations. What can be done? What can be done with all of this research, all of these theoretical frameworks? And so Looking at some older publications, again, I want to bring you back to this idea of income. And so this chart is really comparing what are some predictors of low birth weight for whites compared to blacks. And so for whites who were married, and this is using a population that was considered fragile, for whites who were married, some predictors of low birth weight were age, smoking, paying for the baby's birth with government funding, housing through the government. For blacks who were married, there were no predictors of low birth weight. Now, when we look at single whites, their predictor of low birth weight was smoking. But when we looked at single blacks, again, in this fragile population that typically was a lower socioeconomic status, their predictors of low birth weight were smoking, drugs, paying for the baby's birth with government funding, religious affiliation. When we looked at a national survey of family growth, which is just a general survey that goes out to just random households, and so it wasn't a population that was driven by a lower socioeconomic status. The predictors of low birth weight for whites were working during pregnancy, paying for the baby's birth with government funding, public assistance, prenatal care. For blacks, education, maternal age, paying for the baby's birth with government funding. And so again, what we're starting to see here is that we need to look at marital status and also income. These are two of the emerging themes of drivers of disparities in health outcomes. And to further sum that up, that's not the only thing. There are so many different factors that contribute to Black maternal outcomes, including maternal and child health outcomes. And so if we're looking at the racial and ethnic health disparities in maternal and child health outcomes, this is like the web of factors that I created that really have been driving some of those disparities. And it relates back to those theoretical frameworks. So we have economic stability, employment income, medical bills, financial support. This is one of the things that we're seeing that are really driving those disparities. Neighborhood and physical environment, housing, transportation, neighborhood safety, health facilities, racism and discrimination, institutionalized racism, policies, mistrust, personally mediated racism, education, cross-cultural communication, higher education, food, access to healthy options, community and social factors, support systems, stress, historical and current, health care system, the accessibility and affordability of healthcare, cultural competency, the quality of care. This is really, again, summarizing the factors that are related to racial and ethnic health disparities in maternal and child health outcomes. There are so many, and I hope that you're seeing this through this presentation. It's very complex. It's very hard to say accessibility of healthcare is driving the health disparities, because it's not. There are a host of factors that attribute to the health disparities that we see that we have to address. And so future research needs, we need to continually explore those different stressors, those different factors that are really causing worse birth outcomes for Black women and maternal outcomes for Black women compared to white women. We may want to look at the relationship things. We may want to look at financial problems, again, going back to income, job insecurity. We had to also continually explore the impact of COVID-19. As indicated before, we know that COVID-19 has caused some stress, but how do we connect, and what do we need to really show is that COVID-19 has exacerbated the disparities. We know it. We know it. We know that COVID has caused more stress. We know that COVID has had an impact on incomes. We know that COVID has had an impact on employment. And so we can only project that the disparities will persist, unfortunately, but we have to really discuss how to reduce it, especially in the times that we are currently experiencing. And so future research plans should consist of exploring, again, those stress variables. We need more development on the impact of racism, institutionalized racism, those policies, that structural racism. We also need to get more Black women involved. We need to know and hear from Black women. In this research, we can do all the research in the world. We can look at data, we can analyze the data, but we really need to hear from Black women, hear their experiences, and listen to what Black women are telling us about their experiences. And then step 3, let's make this translatable. We heard you, we heard the Black women, but now let's do something to actually reduce the disparities that we see. So I want to end the presentation with some recommendations. What can we do? We know all the research. We know that it's complex. There are a host of different factors that influences Black maternal and child health outcomes. So what can we do? We need to address social determinants of health and policies. We need to bridge the income gap, paid time for leave. Let's make healthcare more accessible and not be a barrier in other ways. So let's bridge the income gap. Let's give paid time for leave. Let's have access to better environments, education, housing, transportation. I've explored housing and transportation in a lot of research, and there are differences. There are differences in owning a car, for example. That makes a difference. That makes a difference. We need better reproductive education. We need to incorporate mental health into education. We need mental health screenings. We need to address those stressors the best way that we know how. Postpartum care resources. Going back to the discussion on affordability and accessibility of healthcare. We need prenatal and postpartum healthcare facilities in underserved communities, home visiting programs, group prenatal care, addressing the issue of support. Cultural competency. Again, we need to know what's going on in the offices, the providers' offices. We need trainings. We need to train providers about racial and implicit biases. We need a diverse workforce. We need to build trust between patients and clients. We need to listen. We need to listen to the patients, listen to Black women, and we need to re-envision prenatal care visits, driven by the mother, not by the provider. Again, going back, listen to Black women, what they're saying about their visits, what they're saying about their bodies, what they're saying about their stress. We need more awareness about Black maternal and infant mortality. People need to know. I presented today some of the historical underpinnings about disparities. People need to know the origins of disparities. People need to know how bad the disparities are. Why are things the way that they are? We need more education for clinicians, nurses, all health affiliates. And lastly, accountability. We can have all of the things in place, but if we're not holding each other accountable, it means nothing. Quality care measures. How do we ensure that we're giving quality of care to Black women? Observational studies. We need to go observe what's happening in the lives of Black women, what's happening in the doctor's office, their visits. Accountability. So I want to thank you for your time. I want to present my contact information here. If you have any questions about the presentation, any feedback, any thoughts, please don't hesitate to contact me. My email address is sclay@niu.edu. Please email me if you have, again, any questions, feedback, comments. I also have my Twitter tag as well as my LinkedIn profile tag here as well, if you would like to contact me. So again, I want to thank you for your time. I want to thank you for having me. It was a pleasure to talk to you about Black maternal and child health outcomes and give some recommendations going forward. Thank you again. Hope you have a wonderful day.